days, I'm also feeling stressed and depressed. I have not been eating well, sleeping well, etc., etc. So every time I get all these executive checkups done, the laboratory tests, etc., etc., I go back to the physician whom the company has identified for this so-called checkup. The moment I go to his room, the first statement from him would be, "Oh, Anant, you are extremely fine. All laboratory tests are all right. You can go back." So with that one sentence, I used to come back, and I don't know how much my company was paying him. It happened fourth time, and the fourth time my depression had gotten worse. At that time, I had to tell him, "Sir, I have to tell you whether I'm fine or not." And you didn't even ask that question. You have been saying I'm fine looking at my reports. This is something that, not to ridicule any physician, but I'm just saying we also do a lot of errors. As psychiatrists, we miss out many of these medical conditions, medical observations, medical things, and we keep treating him as if there is nothing physically wrong. It happens to both of us. In fact, my professor, on the very first day after I joined MD course, he told me, one professional risk that you have doing a 3-year MD course is that you are likely to forget medicine, what you learned in the last 5 years. So you will learn, of course, psychiatry, but for heaven's sake, don't forget what medicine taught you or the medical college taught you in physical medicine as well. So I repeat it in most lectures of mine. We have to pay attention to both these things. And of course, depression is something that is quite common. How do I change the slides? Oh, yeah. I don't know if the slides change. Oh, yeah. कैसे change करना है इसको? Just to illustrate why the subject is, it's okay, leave it. It's okay, leave it. The 5 points which I have written there, why and then what are the issues that we need to worry about are self-explanatory. Just to indicate that depression causes a heavy disease-induced burden in the society and would rank number 2 today. And there is also a situation. It is often missed in clinical practice. Like I told in the anecdote, very often we don't even ask. Asking happens very infrequently, nor does the chances that this person would say that I have depression would also be infrequent. And in fact, the stigma is one of the reasons why people think that they should not even discuss any psychiatric conditions with the physician whom they are meeting. And of course, the medical illness is also influenced by the associated depression. Remaining untreated has a higher risk of morbidity and mortality with cardiovascular conditions, and the diabetes becomes uncontrolled. These are all well documented research data. I'm not going into those things. You treat the individual, there's more likely to be adherence to medicines, and the conditions of medical nature will also get corrected. In fact, treatment of depression reduces cortisol levels and indirectly would also help the treatment of the other associated medical conditions. And even in cancer patients, survival rates get better because they adhere to treatment. Depression is not a mere sadness, but it is a constellation of symptoms which are fairly classical, well described, well delineated, both mood symptoms, behavioral symptoms, psychological symptoms, and also the biological symptoms of sleep and appetite, in addition to, of course, as I'm repeating, it is not mere normal feeling of feeling sad for some reason or other. We can see depression in varieties. It's a major depressive episode. We have a recurrent depressive disorder which attacks repeat. bipolar disorder where there is a mania attacks in repeated depressions as well. There is also drug abuse related conditions which cause depression. There are several organic conditions, medicines and drugs also cause the depression. And of course, there are depressions which would have been there to the individual, and there is also a medical illness coexisting that would be occurring, dual depressions, that's what we call it. 20% of the primary care people will have depression, and in medical outpatients, it rises by 30%, and in those hospitalized medically ill, it is close to 35 to 40% in different surveys. And neurological diseases are more likely to cause the depression, which includes Parkinson's disease, dementias, strokes in particular cause depressive episodes, depressive syndrome, recognizable and merit treatment. And there is also a reaction to the illness that has been told to him, but that reaction persists beyond a point, and that telling that you have some very serious condition could well be a traumatic episode for him to precipitate a depression in those people who have a predisposition to develop depression. It affects all ages, older more likely to have depression, women more likely to have depression, urban and rural populations both have depression. In fact, a lot of times we say depression is urban located, but it is not true. Even in rural areas, there are more likely to have depression as much as what you have in urban areas. We think that richer people have depression. It is not true. The richer and poorer both have equal preponderance of depression. In fact, there are studies which show poorer more likely to have depression. And more severe the medical illness, the more likely that this person could have a depression. Once you have identified depression, if you don't treat, it may remit. Luckily, many depressive episodes remit spontaneously. But if you don't treat, they are more likely to recur often. The untreated depression produces a lot of disability and of course consequences on unproductiveness and the disease-induced burden on the society. Suicide is a very serious matter. Suicidal thoughts, suicidal attempts, and even success in suicide. Just yesterday evening, I saw a patient who had taken a rat poison in the ward, in the community, and he was treated here by the cardiology department. Suicide is another serious issue related to depression. The medical illness can get worse if you don't treat depression. Anything? क्या हो रहा है? नहीं दिख रहा है? Okay, never mind. You don't have to start the slides all over again. Wherever I have said, I think we will continue. Don't worry, this. Okay, don't worry, sir. We'll complete. Don't worry. I think they're all very hungry, and I think we have to leave. The medical illness gets worse, and then the compliance to medicine gets poorer. So when there is the pathogenesis of depressive episode is as follows. Depression is associated with a lot of NCDs. NCDs lead to a lot of disability, and the disability in turn could cause medical illness. The mental illness, the depression, and this in turn would cause medical illness as well. Medicines which we use in several medical disorders have a potential to induce depression, and the disability that the medical condition causes also contributes to depression. Depression is known to cause acceleration in the aging processes. It's said that Chita dahati nirjeevam, chinta dahati jeevanam. You are continuously depressed. There are a lot of literature which shows that the gray matter is lost in the cortex, and the individual's the chromosome gets shortened, telomere ends. So it is known that these effects are very common if depression remains untreated, and so we have to treat the condition. So diagnosing depression is something not very difficult. In a medical practice, he may not necessarily say that I am depressed. If he says that, it is of course easy, anyone can diagnose depression. But there are some tips that I will give, which very often there are symptoms which are not explained by the current medical illness or any known medical illness, which should warn you in an individual that too middle-aged plus that he could well have depression. The severity of symptoms, what he says, seems to be out of proportion to what otherwise that illness would perhaps predict by way of the various laboratory findings, etc., etc. His illness seems to be severer than what I would have otherwise expected. The course gets changed over course of time. Unexpected change of course. There was a person who was admitted with a mild stroke. He had a dysphagia, expressive dysphagia in the ward, and he was discharged. To be discharged, 4 or 5 days later, his speech had become much better, and of course he had no motor symptoms, but he was plagued with the fact that he was not able to really understand what others said. They had some difficulty in understanding what communications that were going on. But he was doing very well. And on the 6th day or 7th day, when the discharge letter was written, the family settled the bill in the morning. Towards the afternoon, he said, he started showing that I'm not able to speak. I'm not able to speak. He started showing, but he didn't say it. And the neurologist thought, okay, we'll hold on for a day or two. In a day or 2 or 3, the course had changed and the symptoms of depression started coming. Although we might call it dissociative symptoms, but these are all symptoms of a preluding to a depressive episode emerging in this individual. The person has had a reaction to the illness, which has been told, but this reaction continues for longer than what you would have expected. Then, of course, this is again to be considered as a major depression. And of course, you have to make sure that whatever depression that is expressed and symptoms lasting for 2 weeks or longer and producing more disability, severer forms of symptoms, and his course has changed and he is not sleeping well, he's not eating well, he's not taking medicines regularly, you should all think that a full-blown depressive episode has happened and you have to suspect and then treat the condition. Yeah, like I said, there are some symptoms, a constellation of symptoms that have been described in depression, a mood of depression. You see this person weeping, crying off and on. He expresses hopelessness and a very low self-esteem. I'm not worth living, suicidal thoughts, guilt, I don't know what I did. I have been given this disease in this period. He is probably very retarded or very agitated. He could be having very poor interest in day-to-day activity, including caring for himself or the medicine that he has to take. Appetite is lost. And even the weight could be reduced, and he has sleeplessness, significant sleeplessness. You are forced to give some medicines in the hospital. There is a lowered drive for sexual activity. There are poor concentration. A fatigue is another very common symptom. Retarded and agitated, as I already said. Menstrual changes are also noted in these people with the depression. So a constellation of symptoms, 5 or more symptoms, typically is considered as a major depression. 4 or fewer symptoms are also called as a minor depression. The minor form of depression lasting for 2-3 years, we also call it as dysthymia or dysthymic syndrome. So having seen these things, evaluate the person thoroughly, and you have to see how severe is the condition, particularly when the individual has got suicidal ideas, biological disturbances. Yes, of course, he needs more serious attention as far as treatment is concerned. But most conditions that you would come across in medical practice would be under the section of what we may call as mild depressive episode. It won't be very severe, unless, of course, there was a pre-existing episode of depression in this individual, and this medical illness would have caused a recurrence, and it could be as severe as it was in the past. If it was not so, more often than not, the depressive episodes are usually mild in these individuals. And when you are treating a mild depression, there are some simple tips that you can follow. You have to promote physical activity if the physical condition permits it. And typically, I prescribe yoga for these people with mild depression. I also ensure there are so many medicines that they would be taking which may not be necessary, which you as a physician would be able to better decide whether these were required or not. And you have to listen to the individual. like Dr. Gangwar was saying, listening is half cure. Listen to the individual, and much more so when the individuals have psychological symptoms. And of course, you have to give a reassurance. Reassurance does not mean you have to falsify, you have to say what is fact, but the fact that is said in such a message which actually communicates the individual the right message with the degree of confidence that he need to have in terms of the treatment outcome that it is going to give. Satyam bruyat, priyam bhuyat. Na bruyat satyam apriyam. Priyancha nanratam bruyat. Don't say something that is a lie just to please the individual. So these things have been told in our Subhashitas. All these things are very helpful in medical practice, the ATCOM module in particular. So there are people who facilitate group interactions. There are groups that have been formed in HIV groups, cancer groups, and the host of those things, alcohol, drug abuse related groups, where when they all discuss their relations, their problems, their symptoms, they will feel I am not alone. There are people with me, and I feel I'm going to get better. And of course, if there is a medical condition, I'm sure all of you, although I would say this to my psychiatry residents, I don't have to tell you, but I'm sure you're already applying your mind to correct the medical condition. Medicines in my moderate and severe depression, I'm giving you only 3 medicines here. I'm not giving a big list of medicines. In fact, there are as many as about 50 odd antidepressant medicines that are available. Something that would be reasonably safe. The SSRIs, among them, my preference is to use sertraline, 50 to 100 mg. And if there is a hepatic insufficiency or renal insufficiency, I use a lesser dose, about 30% if there is a hepatic insufficiency. And most of the SSRIs are reasonably safe, even if there is a renal insufficiency. But I would still start with a lower dose and go up for them. Mirtazapine is a very useful drug. The only caution is I don't generally prescribe mirtazapine to people who have a known hypertension and getting medicines for hypertension. It is fairly safe in hepatic insufficiency or even for that matter renal disease. Nonetheless, a common thumb rule is I use a lower dose than what the others. Bupropion is a very good drug. It's a very good drug which produces more activity in a person who is lethargic. And of course, the end stage renal disease is a place where you have to perhaps make sure that the medicines is used in caution. Otherwise, it's a reasonably safe medicine. You also have to consider when you want to have a collaborative care. When I'm saying collaborative care, you want to involve the psychiatrist in your hospital if he or she is available, or you're going to consult him. When is it needed? If there is a known past history of a psychiatric disease, depression or otherwise, it's a good idea to do this collaborative care, because the patient wouldn't tell, he would have stopped the medicines, and you would perhaps not know at all whether he needs to continue the medicines or not. So that consultation is useful to whether he should be restarted on those older medicines or you have to give something else. And psychiatrists would also know what are the drugs which this person has in the past tolerated. So that's another benefit that you will get if there is a old history of a psychiatric illness in this given individual. And of course, if the present interventions, what you have done, SSRIs, you have given 50 mg of sertraline, and you have done some counseling, explained the individual, explained the family, but still something is going on and is not getting better. And so you are also not able to increase sertraline from 50 mg to 100 mg. For various reasons, you are worried, and you suddenly identify the drug interaction with the drug that you are giving. Today, all of us have forgotten to teach in the classrooms the drug interactions, because students know more about drug interactions. Patients know even more. They check the Googles and so on and so forth, and then they know what the side effects, which drug or which causes, which should be taken or should not be taken. But nonetheless, when you know that you cannot afford to increase the medicine for this individual, what else we can do for this individual? Suicide risk being very high, again, do you have to do something else? You want to give treatment other than just the medicines, is a consultation that would help with the psychiatrist. And of course, when the medical condition is still significant, you would have otherwise, if you had gotten better, you would have discharged when the medical condition was stabilized to go to a psychiatrist. The psychiatric condition is very significant, but the medical condition is also significant that you can't discharge the patient. So at this time, of course, it's a good idea to call the patient, call the psychiatrist to help you out. So I'll summarize. It is commoner in medical ill than we all thought. It is often underreported by the patient, under asked by us as well. So keep a watch, 2 or 3 questions. There are, of course, several instruments that are available to detect depression. I'm not going into those theoretical things. Simple thing, how are you? How is your mood? How are you feeling? How lively you are? How are you able to attend to your family course? How are you able to attend leisure activities? Do you enjoy the same TV program, the newspaper, or the stories? Enjoy playing with your family members? A lot of what we may see as common sense questions which elicit also depression. If you don't treat, there are some adverse consequences which I have already mentioned. Chronic medical illnesses and depression share some common factors which includes lifestyle. Please ensure that the lifestyle is made as healthier as possible for this individual. Diagnosis of depression is possible with a known constellation of symptoms. The slides are here, so if you want to use it, you can use it. There are treatment options from non-medicine related treatment to medicine related treatments, and of course something beyond the medicines as well, what we may call as the electroconvulsive therapy. Non-medicine treatment include lifestyle advice, counseling, emphasizing some of the yoga practices which he can afford, and of course medicines, I said SSRIs, mirtazapine and bupropion. And always consider the non-drug treatments as the first line. Unless the condition is so severe, you have to call a psychiatrist. He or she may think of an alternative treatment. That is drugs. So I'll stop here. I bow to Ma Saraswati for blessing me with all this wisdom to share with you. And I also am working in this yoga center as the Professor Emeritus of Integrative Medicine at NIMHANS at this point of time. Because most often my introduction was I am the commission chairman of NMC, but NMC activity is a non-academic activity, but this is an academic activity. I thank each one of you for being there, and I'm sure you're all very hungry, if not angry, but Dr. Gupta ji has made a big feast for you. Thank you. This is my email. If there are anything that you want to share with me, I'll be happy to respond to you later on. Thank you so much.
Thank you, sir, for this informative presentation. It was incredibly insightful and helpful. Now, I would like to welcome Dr. Manoj